Good morning to one and all. I'm Karen Zadhav, and it is my privilege to welcome you all to this webinar. As healthcare professionals, we can all agree on a well recognized fact in the world of pharmacology: the concept of one size fits all is a myth, and we are constantly seeking ways to metabolize the complex information, and renal and hepatic dose adjustments are a key part in the process of tailoring treatment for the individual. Our today's speaker, Dr. Atharva Nanday sir, is a highly accomplished PharmD professional and has an exceptionally comprehensive understanding in not only pharmacology and pharmacotherapy, but also in the established standard treatment guidelines. Sir has not only rooted in his academic training, but also has an experience in the clinical field, having successfully completed a clinical pharmacist internship at three esteemed institutions: Jahangir Hospital at Pune, Deenanath Mangeshkar Hospital and Research Center, Pune, and Jupiter Lifeline Hospital at Pune. He has showcased exceptional dedication and expertise and now serves as a full-time professional at Jupiter Hospital, further enhancing his reputation in the field. His contributions to the field are notable, with two impactful research articles and four well-regarded case studies published during his PharmD curriculum. We are truly privileged to have him with us today. His profound knowledge and clinical expertise are sure to enhance today's discussion, and we are eagerly anticipate the insightful perspectives he will offer. I now hand over the session to you, sir.
Good morning, everyone. Thank you, Karen, for that wonderful introduction. So we can start once the slides are up, right? Mm, are we good to go? Yeah. So let's start. So we are today going to discuss upon the renal and hepatic dose adjustments by a case-based approach. Okay. So first, next slide, please. Let's start with first renal failure and understanding the anatomy and the physiology of the kidneys. So we do all know that kidneys are the one pair of organs which are located below the rib cage and besides the spinal canal on the peripheries of your body, and they are mainly responsible for excreting metabolic waste. Okay, maintaining body fluids and acid base balance. As you can see here in the picture, there is an external view shown and an internal view shown of the organ, which contains cortical vessels, interlobular vessels, renal artery, and renal vein being embedded into the organ. It shows the minor calyx and a major calyx where they intersect in the kidney, followed by a pair of ureters, and all of this is encapsulated in a capsule. Okay, so what is the basic structure which is responsible for doing all of these functions? That is the nephron, which is shown on the right side. Okay, so nephron is per highly perfused organ with a renal artery and renal vein. It contains a glomerulus, which you can see, and inside it is embedded the Bowman's capsule, which is mainly responsible for all the filtration going on around in the kidneys, followed by the urinary flow or the flow of the fluid, which is into the tubular part of the nephron, followed by the collecting duct, and below it, it is the loop of Henle, wherein all the distribution and the exchange of the proteins or minerals or all the balances or electrolytes, etc., takes place. Okay, please, next slide, please. So, what exactly is renal failure? Renal or kidney failure is the condition wherein the kidneys fail to filter out or remove toxins from the blood. Okay, in scientific terms it is termed as decrease in glomerular filtration rate. So glomerular filtration is what the amount of the fluid which is cleared out, or which the urine the kidneys go through with it to clear out all the excessive matter or the toxins. So GFR, as per KDIGO, that is Kidney Disease Improving Global Outcomes, it is an organization which talks about kidney health and gives us guidelines to manage kidney diseases. So a 90 or higher of GFR is considered as normal. In the limits of 60 to 89, it may indicate an early stage renal disease. In stages of 15 or 59, it may indicate kidney diseases, and below 15, it is a definitive diagnosis of kidney failure. So these are the comprehensive GFR ranges which are standardized by the KDIGO. Next slide, please. So what are the causes of kidney failure? So mainly we can attribute four causes. Okay. So in this, first is the disease conditions. Disease conditions might include genetic diseases as well and acquired diseases as well. Under genetic conditions, that it might be polycystic kidney diseases, which is a genetic predisposition wherein the cysts occur inside the kidneys, which hamper the kidney function. In case of acquired diseases, it can be anything ranging from hypertension, diabetes, any heart related conditions which might hinder the renal blood flow are attributed to this. Next are the social habits. Okay, any use of recreational substances, any kind of drugs, smoking, alcohol, or any other consumption of toxins. Apart from that, and any lifestyle, what we can say, mishaps or not following a proper lifestyle may contribute to your renal failure. Next accounts for direct trauma, that is any injury to the chest, abdominal, or pelvic wall. It can be a penetrating injury, it can be a damaging injury which might cause kidney failure and hence lead to hypoperfused kidneys, in turn creating problems. And next are the drugs. There are many drugs which we will further discuss, so let's not elaborate much on that right now. Next slide, please. So what are the symptoms? Just a second, sorry. So what are the symptoms? So kidney dysfunction may have very common symptoms and some of rarest presentations as well. The common ones might include nausea, vomiting, which are always attributed with all the other disease conditions as well. Apart from that, the characteristic symptoms specifically include oliguria, that is decreased urine output or decreased urination. Decreased mental sharpness can also be a symptom due to deposition of uric acid and uremia, that is blood urea nitrogen. Muscle cramps can be a sign due to electrolytic disturbances. Swelling of foot and ankles, which is a consistent symptom that we can call it pedal edema or inguinal edema. Persistent pruritus, again, which can also be a reason of uremia. Shortness of breath due to pulmonary edema, that is fluid deposition inside the lungs from fluid overload. And next is hypertension. Okay, so some uncommon symptoms might also be presented in kidney failure, such as skin pigmentation, which occurs as a result of, again, uremia. Scratch marks from pruritus. A person or patient might experience itching all over the body surface area due to excessive deposition of uremia. Pericardial friction rub due to uremic pericarditis. It is basically a cardiac fanding wherein the uremia or the toxins which are not filtered out of the blood are deposited in the pericardium and which produce a scratching sound, or how if the sound which is produced after we scratch a specific table or specific surface, it is such a sound which is due to the deposition of uremia. Uremic frost is another symptom wherein burn is highly present in the body and which accounts to sweaty appearance or whitish crystallized appearance on the forehead, or it might be presented as sweat, white sweat through your skin pores. And next is hyperreflexia. Next slide, please. So as we have discussed what is what is kidney, how the kidney functions are attributed. Okay, so let's discuss how the is the kidney function measured. So glomerular filtration rate is the most widely used and accepted measure to assess kidney function. The GFR is the measurement of volume filtered through the glomerular capillaries and into the Bowman's capsule per unit time. So it can be attributed as amount of fluid being separated or being passed through the kidney in per unit time. Here per unit time accounts for 1 minute. Okay, So filtration of the kidney depends on the difference in high and low blood pressure created by afferent and efferent arterioles as well. So it is directly proportional how much input you put in and how much output you are getting. It's the basic sense of that. So how is kidney function measured? Creatinine. We all do know that creatinine is a byproduct of creatinine phosphate during muscle metabolism, which is used to measure GFR, and it is not reabsorbed at the glomerulus. So excretion of the creatinine always varies with age, gender, weight of the person, especially in case of obese person, or obese patients. As the muscle mass might be low, they can significantly impact the levels of creatinine and hence present with lower creatinine levels as well, which generally proceeds to the higher side. And in case of elderly patients, it is always low. Generally it is low. It is a generalized scenario because muscle mass does deteriorate among as the age progresses. Next slide please. So what are the types of renal failure? So there are two types, mainly acute renal failure and chronic renal failure. So acute renal failure is a characterized by oliguria, as I previously mentioned, that is a decreased urine output, or anuria as well, that is no urine output at all, accompanied by an electrolyte imbalance. Okay, it is also defined in terms of increase in serum creatinine in multiples of zero point 0.3 milligrams per DL within 48 hours, or steady state increase over the course of few weeks or even months. Okay, so there might be such a damage to the kidneys. It might be due to hypovolemia. It can be a result of trauma. So the as the perfusion is decreased, serum creatinine does rise and goes into the multiples of zero point 0.3 mg per DL. Okay, this is AKI, that is acute kidney injury. And next is chronic renal failure. It is characterized by over the time loss of kidney function, which can span over months to years, wherein normal structure and function of the kidney is changed. Next slide, please. So this is a structural and functional criteria as defined by KDIGO. So it does contain four disease conditions: no kidney disease, chronic kidney disease, acute kidney disease, and acute kidney injury. Mind you, there is much more difference in all these specific conditions that we will see one by one. So firstly, there are three parameters: duration, functional criteria, and structural criteria, which might or might not be contributed to the above both criteria. So duration: if the kidney injury or there is a rise in serum creatinine by 50% within first 7 days of any kind of symptoms, or increase in creatinine, as I previously mentioned, zero point 0.3 mg per DL increase in multiple increase in approximately 48 hours or within 2 days, and or oligouria for more than 6 hours, that is there is very low urine output or decreased urine output or no urine output at all in the patient, it can be attributed with AKI. So structural criteria is not exactly defined because these processes do happen in a much hasty way. So as such, no structural observations are made. Okay, followed by AKD, that is acute kidney disease. So its duration spans over more than 3 months, which are characterized with AKI, which we can match all the previous parameters into acute kidney disease with a GFR of less than 60 ml per minute. As I had mentioned previously, a GFR of less than 60 ml per minute per 1.73 meter square of body surface area. It is the average body surface area which is considered for a normal human being. So if it is 60 ml or less, it is definitely a kidney disease. It 100% denotes that something is wrong with the kidneys. Okay. So next is decrease in GFR by less than or equal more than or equal to 35%, or increase in serum creat levels of more than 50%. So marker of kidney damage is albuminuria, hematuria, and pyuria. Okay, albuminuria, albuminuria is the presence of proteins in the urine. Correct. Also, hematuria is presence of blood. So these can be definitive parameters for suspecting or confirming the diagnosis of kidney injury and kidney disease. Next is CKD, which is a chronic kidney disease. It spans over more than 3 months and definitively indicates that permanent damage has been set in to the kidneys. GFR is always low in these kind of patients, and or there is also marked kidney damage. The kidney might become, it means that upon the radiological findings you might see that there are various changes occurring inside the kidney. So also normal marker for this is albuminuria. Next slide please. So, what is the classification and presentation of renal insufficiency? This is another National Kidney Foundation's criteria, which all of us might have studied. So, it is characterized into six types according to the GFR. Again, in G1 and G2 phase, G1 phase is a normal disease condition or no disease condition as well. G2 phase is characterized by, of course, decrease in the GFR, wherein it can be mildly decreased as a presentation of kidney damage, that is nephritic syndrome, which can denote inflammation of the nephrons. Urinary tract symptoms can be there, obstruction can be there, asymptomatic urinalysis abnormalities can be there, there can be pus cells, protein cells. Okay, so asymptomatic radiological abnormalities, the if the clinician performs an MRI or CT, there are much more evident findings on that. Also, the patient does present with hypertension. Next is G3A and G3B. So, differentiating between these two stages is actually mild to moderate decrease of difference between approximately 15 ml per minute GFR. So, mild to severe complications can be seen, which are characterized by anemia, mineral or bone disorder, parathyroid hormone elevation, lipid abnormalities, and as usual, lower serum albumin. So G4 is severely decreased GFR, and G5 is characteristic feature of kidney failure which necessitates dialysis and or renal transplant. Next slide please. So this is the slide of our importance, that is causes of AKI. So here I have the list. Many causes have been listed. We do know that there are three types of AKIs: pre-renal AKI, renal AKI, and post-renal AKI. Pre-renal AKI mainly accounts for decreased blood supply to the kidneys. Renal is the damage has been set in within the kidneys, within inside the organ, and post-renal AKI accounts for the bladder and the ureters. Okay, so there might be an obstruction due to kidney stone, or strictures might be present. There can be damage, epithelial damage to the ureters or the bladder. So in pre-renal AKI, as I said, hemodynamic alterations, that is blood perfusion is reduced. It can be a result of low cardiac output due to negative inotropic drugs like beta blockers, systemic vascular resistance due to vasodilators. If the vessel is too much dilated, there can be a hypoperfusion. Renal vascular resistance, which is attributed to NSAIDs, COX-2 inhibitors, cyclosporin and tacrolimus, and transcapillary pressure, that which is the characteristic finding of AC inhibitors and ARBs. So now moving on to renal, that is intrinsic within the kidney. The problem lies within the kidney. Okay, so these are the drugs which cause damage within inside the kidney. So first is acute tubular necrosis can set in, which is a result of amphotericin B. We do all do know that amphotericin B is a very highly nephrotoxic compound. There are three forms available, which lipid, conventional, and the normal form. So we do usually use lipid form as to minimize the kidney damage, and we also pre-medicate and fluid the load the patient with fluids. So acute interstitial nephritis is also can be finding, which is due to antimicrobials, COX-2 inhibitors, NSAID, PPIs. So all these followed glomerular nephritis can also be there, but it is a more common finding that interstitial nephritis is the most common one encountered in practice. So these findings are evident from a radiological test or a kidney biopsy. Okay, so we do need kidney biopsy to determine what exactly the type of damage is, and correlate it with the treatment being given. Next is post-renal AKI, which is precipitation of drugs in renal tubules. Example, sulfonamides can be there, antiretrovirals can be there, and as I previously mentioned, anticholinergic bladder obstruction can be there. So anticholinergics do cause detrusor muscle activity is decreased in that. So there can be a delayed emptying of the bladder, delayed emptying of the urine. So it can be a cause of AKI. Next slide, please. Okay, so let's learn the calculations. So creatinine clearance. This is the main what we can say parameter upon which we assess the kidney function in kidney disease. It is defined as the volume of plasma separated of creatinine in given unit time. Okay, so formula is ratio of urinary excretion of creatinine divided by serum creatinine. So mind you that reduced glomerular filtration rate is directly proportional to the rise in serum creatinine. Whatever occurs if the kidney is less perfused or the blood is not reaching the kidneys, if there is any kind of abnormality within the kidney itself, there are chances that there are not chances. It is definitive that serum creatinine rise will occur. Next slide, please. So, what are the different methods used for calculation of creatinine clearance? There are four methods mainly: Cockcroft-Gault equation, estimated glomerular filtration rate through MDRD study equation, CKD epidemiology collaboration, CKD EPI, and Schwartz equation in case of pediatrics. Okay. So, next slide, please. We will discuss each method one by one. So Cockcroft-Gault equation, it is the most widely used actually equation over in all practice settings. So what does it give us? It is gives us a formula of 140 minus age, where into ideal body weight, where we use ideal body weight of a person calculated upon by the formula given below it, divided by 72 into serum creatinine, multiplied by 0.85 ml per minute in case of females. So this factor is used in case of females as to make up to the mass of the muscles, because uh, females genetically predispose a higher fat mass. So to compensate that, what we can say ratio, this multiple has been used. So this equation gives us the creatinine clearance ml per minute of the body surface area. Next slide, please. EGFR through MDRD study equation. So MDRD, modification of diet in renal disease. So this equation has been constantly being updated, and currently it is the most widely used and accepted equation. But still, we do prefer EGFR, the Cockcroft-Gault equation over it in practice. So how it is calculated? The GFR 175 into serum creatinine. So, yeah. Okay. So GFR 175 into creatinine raised to the power of minus 1.154 into age. So these power constants are derived mathematically. So we do not go into much details of that. So this is an equation which we can use upon racial purposes as well. If in case we are calculating creatinine clearance of African American patients or any other Caucasian patients as well. So this equation is mostly used for that. Next slide, please. Yeah, no, the previous one. Previous slide, please. It's the fourth. Yeah, thank you. So CKD epidemiology collaboration. It is also an organization which gives us same as I think so. No, means the parameters are the same. They remain the same. We use serum creatinine, age, gender in this case as well, and we do use the racial parameter in this case. Next slide, please. Schwartz formula. So in case of pediatrics, wherein all the their bodily functions are different, their organs are not yet well developed. So we do use Schwartz formula, which is EGFR calculated. Just a second. So EGFR calculated is equal to K. K is the constant which are mentioned below. They do differ as per the infant age and term, divided by serum creatinine in K into length, that is the height of the patient, divided by serum creatinine. So in case of pediatrics, currently, as we know that no specific dose adjustments schedules or guidelines are available, so we do have to rely on clinical expertise and all of the other patient parameters on how the patient responds to the therapy. We can use this formula to definitely dose patients according to their creatinine clearance. Yeah, let's go ahead. Next slide, please. Yeah. So issues. What are the issues which happen during drug dosing? There can be continuous change in serum creatinine. The creatinine might keep rising even you are whenever you are reperfusing the patient, loading the patient with more fluids. Okay. So there can be again increased volume of distribution due to rapid fluid correction and or decreased protein binding. Okay. So as we are loading up the patient, there is more fluid accumulation in the body. There can be intrinsically more accumulation of fluid in the body as the kidneys are not excreting the fluid. This might often affect the protein binding as proteins are getting excreted out of the body through the kidneys. The liver, which is a primary organ responsible for production of albumin or the proteins, it might reduce the protein production, and hence there can be decreased protein binding. So decreased protein binding generally affects the drug's elimination. So there can be increase in non-renal clearance and decrease in renal clearance. So here non-renal clearance accounts for clearance or excretion of drugs through other pathways. It can be bile, sweat, okay, stools, etc. All the other types of pathways. It can be through perspiration, through the lungs. Okay, and decrease in renal clearance. Role of renal replacement therapies. So renal replacement therapies, we are going to see it further, but they are the mechanism which we use as a last sort to depreciate the kidney function. So alteration in drug receptor sensitivities. It is not a much more studied phenomenon, but yeah, yes, that does occur, that the receptor sensitivities might get affected in patients with kidney disease. Moving on to next slide, please. Yeah, so we are into the main part of the presentation. What can we do as professionals, as PharmDs or as clinical pharmacists? What we can do on our part to adjust the dose? There are three treatment strategies mainly: reduce dose or prolong dosing intervals. So either or, this is, we can do both, we can do one of it. It depends on the patient to patient scenario. Alternative options we can use, specifically if for example any drug is contraindicated or is not to be used in the kidney failure patients, we can switch to other options as well. And therapeutic drug monitoring is one option wherein we can determine the drug levels in, especially in case of antimicrobials. Next slide, please. So moving on to renal replacement therapy. So RRT encompasses life supporting treatments for renal failure. It is indicated when patients are in case of AEIOU. Okay, so these are the, this is a, what we can say, acronym for that. So severe acidosis, firstly, blood bicarb level of more than 12 milli equivalent per liter and low pH. Sorry, just a minute, give me a minute. Sorry, the light was flickering. Sorry for the disturbance. So electrolytic abnormalities, hypokalemia and hypercalcemia. As we previously did see that there can be significant electrolytic imbalances. Next is eye ingestion or intoxication, the wherein the patient might present us with consumption of unknown molecule, or patient can be intoxicated with alcohol or any recreational drugs as well. Fluid overload, evident through shortness of breath, that is dyspnea, and edema of hands and feet, wherein we can see fluid being accumulated inside the patient's body, and uremia, that is blood urea nitrogen of more than 40 millimole per liter. Next slide, please. So, renal replacement therapy is basically what we can understand, that we are using artificial machines to remove all the kidney, all of the part of the toxins or electrolytes or whatever metabolic waste it may be, through mechanical ways. Okay, we are not loading the kidney, we are helping the kidney to do its job. Okay, so what are the modes of RRT? First is intermittent hemodialysis. Next is peritoneal dialysis. Will not go into much or details of that because it is a very complex procedure. Third is the CRRT, that is continual renal replacement therapy. It includes three more types, which are continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, and continuous veno-venous hemodiafiltration. Okay, so there are the different principles involved in these cases. So hemodialysis usually uses a diffusion principle where the molecules move from higher concentration to lower concentration. Sorry, continuous veno-venous hemodiafiltration, where is we apply pressure onto the blood, wherein the pressure, as a result of the pressure, the molecules switch from the blood component into the solute component, which is being used for filtration. And next is SLED, that is sustained low efficiency dialysis. So we keep the patient overall connected to the machine for 24 hours, wherein we do separate the plasma or filter the blood by in steps. It is done very slowly. In short, the main mechanism, as I mentioned, this convection, transmembrane pressure, and diffusion. Next slide, please. So how do the CRRT and drugs deal? So, what are the drug parameters which might get hindered? Protein binding. More the protein binding of the drugs, less is the clearance. So, protein binding is affected in kidney patients, as a protein loss. Albuminuria does occur profoundly. So, it might hinder with the drug being less protein bound and less available for excretion as well. So, next parameter depends on the molecular weight. Similar concept as to protein binding, more the molecular weight, less is the clearance. Okay, so heavier or bulkier the molecule, less is the clearance. It's as simple as that. Next is volume of distribution. This is an unhingeable phenomenon, but still considered as CRRT employs very slow flow rates and drugs might be able to distribute. Okay, so as the volume of distribution does increase, it can be evidently said that the drugs get distributed inside deeper into the body tissues and arteries or anything. So the drug is less available to be getting excreted outside the body. So further, we are going to see case discussion. So technical team, can we have feedbacks of the? Can we activate comment section somehow so I can get feedbacks as we are going to discuss cases? Is it possible for us? Okay, so comments have been activated. Yeah. Can we have the presentation side by side? So, just, yeah. Next slide, please. Yeah, so let's discuss one case. So Mr. LV is a 35-year-old male patient weighing 50 kgs was admitted into our setting with complaints of herpes simplex encephalitis. The condition was diagnosed in the previous setting. From that setting, patient came to our setting, fever, headache, and confusion. So he was starting on following medications: acyclovir 500 mg IVDDS, brivaracetam as a seizure prophylaxis, MVI, that's multivitamin, one ampulin 100 ml normal saline, pantoprazole for stress ulcer prophylaxis, acetaminophen, trypsin, chymotrypsin, and N-acetylcysteine. On the third day of treatment, Mr. Lee's serum creatinine increased from 0.8 mg per dl to 2.5 mg per dl. Okay, so the laboratory results showed a 2.5 mg per dl. Mind you, it has occurred within on the third day of treatment. Okay, so patient has been given, I think so, yeah, if my calculation is right, almost 9 doses, sorry, 6 or 7 doses of the all of the therapies. Okay, so there is blood urea nitrogen increase to 40 mg per dl. Electrolytes of hyperkalemia show hyperkalemia 6.2 ml equivalent per liter, and urinalysis with specific gravity of 1.20. So what can be the likely diagnosis? People watching this, please guess your make your guess. Are they responding? I cannot see. uh, People, please tell me what has happened here due to the therapy which we giving to the patient. Please respond so we can move on to next. Are there any new responses, or I can move on if no one has anything to say? So why has this increase in serum creatinine happened? Please take your guesses. There are no responses. Okay, no problem. So we can at next. Can we on the presentation? Yeah, the next slide, please. So as no one has made any kind of guesses, let me tell you. Please put in presentation mode. Okay, sir. So this is the case of acyclovir induced AKI due to crystalluria and tubular absorption. Okay. So acyclovir, we do know that acyclovir and its other valcyclovir or valganciclovir are these are the drugs which are known to cause crystalluria. So what are the next steps we need to follow? Acyclovir was immediately discontinued and the patient was hydrated with IV fluids to prevent further kidney damage. Okay, we were administering the patient with 500 mg dose in 100 ml of NS, but still it was not adequate hydration. Again, patient was separately put on hydration of I think so 500 ml of 1 pint of NS per day. Still, it was not enough. Hence, we did see this case. The patient electrolytes were closely monitored and hyperkalemia was managed with potassium binding resins. Okay, Renal replacement therapy was considered, but the patient's kidney function improved with supportive care. So what we did, we firstly stopped the drug, which is the first thing to do. We did hydrate the patient to prevent the crystalluria and setting in permanent damage. So plenty of fluids were given to the patient. Okay, so Mr. Elvis AKI resolved within 7 to 10 days with a return of his serum creatinine to baseline levels. Okay, as the patient's hydration improved, we loaded him up with fluids. So Mr. Elvis AKI was gradually resolved. Then the patient was started on valcyclovir, an alternative antiviral medication, to complete his treatment course for herpes simplex encephalitis. Yeah, next slide, please. So this was a case of acyclovir induced AKI. Next, we are going to see a case of CKD. Next slide, please. So, sorry. So, what are the key takeaways? Acyclovir induced AKI, particularly in patients with pre existing kidney disease. Hmm. What is it? I cannot see the presentation. So, let the technical team resolve it so we can continue. So we did see a case of acyclovir induced AKI wherein the acyclovir did cause crystalluria and damage to the kidneys. It was an acute damage or a short-lived damage. So crystalluria and tubular obstruction has occurred where, as I previously mentioned, cyclovir can precipitate in the kidneys, causing crystalluria and tubular obstruction, which can lead to AKI. It is a known adverse effect. So, what can be done? Monitoring and prompt intervention. Closely monitoring the kidney function is very essential, and intervention is always better. Next slide, please. So, we are dealing with case 2 here. Mr. P, a 60-year-old gentleman, came to us for a routine checkup. He was a known case of hypertension, type 2 diabetes mellitus, stage 4 CKD with EGFR of 30 ml per minute per 1.73 body surface area. So he was on these medications, tab metformin 500 mg, extended release tablet per oral BD, tab lisinopril 10 mg per oral OD, atenolol 50 mg per oral OD, and simvastatin 20 mg per oral OD. So yeah, these were the patient's medications. So please give me some answer that what all medications do need adjustment. You can take a random guess, no matter if you are wrong. Please take a guess. What you guys do think that what can be adjusted or what can be kept the same? Can we have the comments? Are there any responses? So okay, people had responded. Okay, the addition could be each person had right kidney nephrosis, urinary transfer. Only one metformin must be prescribed once. Okay. Tab atenolol 50 mg needs change. Yeah. Okay. Anything else? No, these are the previous questions. We can address the questions later. Yeah. Anything else? Metformin. Okay. ठीक है. चलो. Let's move on. So next slide, please. So patient was on 4 medications. Okay. So 4 out of 4 we will see what can be adjusted and what cannot be, or what we can keep the same. Next slide, please. So first is metformin. So maximum recommended dose of metformin in CKD stage 4 is for 500 mg once daily. Okay, so as someone has had mentioned, 500 mg of metformin should be given daily. Mr. P's dose should be reduced to 500 mg once daily to minimize the risk of lactic acidosis. Not necessarily ki lactic acidosis will set in immediately, but yeah. So here we can have two options. That is, we might use the extended release tablet as well, or we can switch to a normal tablet, means which is a normal coating, not an extended release tablet, wherein we can use this that formulation to what we can say, means optimize his blood glucose levels. Next is ACE inhibitor, that is the lisinopril. The recommended starting dose of lisinopril in CKD is 2.5 to 5 mg once daily. So Mr. P's dose should be reduced to 5 mg once daily to minimize the risk of hyperkalemia. Okay. Next is atenolol. Atenolol, I think so, will can remain in the same dose. The recommended dose is 25 to 50 mg once daily. Hence, if no hypotensive episodes or any other cardiac complaints or anything else the patient is complaining of, we can continue with the same dose. And next is simvastatin. Simvastatin is primarily metabolized by the liver, and its dose does not need to be adjusted in the CKD. So, what all adjustments we have done? We have adjusted metformin. We can switch between the tablets as per the glycemic control is established. We have changed the dose of lisinopril. Okay, as it is an ACE inhibitor, it is major contributing factor to cause hyperkalemia. Okay, the patient is of CKD, so we do need to use it carefully. Yeah. What are the key takeaways? Next slide, please. So whether the patient is in admission, means we are treating the patient, or whether the patient is on OPD basis, periodic renal function assessment is always necessary, and based on the assessment of the function, the clinical decision of the adjustment is made. Next slide, please. Please let me tell you that we will address all the questions in the end. So we can move on to liver failure. Yeah. So firstly, understanding anatomy and physiology of the liver. So as you can all see in the diagram, liver is a much larger organ. It has two separate anatomical divisions. We can see that it is being separated into two lobes by the inferior vena cava and the central vein. It can weigh up to 2 kilograms and accounts for 2% of adults overall body weight. Okay, so, and it is very richly supplied with blood. You can see that the hepatic artery and hepatic portal vein are originating from downside. The gallbladder is situated. We can see the whole liver structure with highly perfused branches of the blood vessels. Next slide, please. So liver is a very important organ. Okay, it has some of the mentioned functions which I have mentioned here. Mainly there are 6 primarily of importance. First is metabolic functions, that is which deal with carbohydrate, protein and lipid metabolism. So it regulates blood glucose via different mechanism. It manufactures proteins, they regularizes their release into the blood and converts ammonia to urea. In case of lipids, it synthesizes cholesterols, or it helps in maintaining the lipid metabolism. Next is detoxification and excretion. So drug toxin and metabolism metabolizes drugs and toxins via phase 1 CYP450 enzymes. I hope everyone is aware of these enzymes. These enzymes are mainly present in the liver, which metabolize. They can either reduce the drug or activate the drug into its active form so that it can show its action. Next is bilirubin metabolism. It converts hemoglobin breakdown products into conjugated form for excretion. And ammonia, it also does ammonia detoxification. In case of digestive function, it secretes bile, which is of very important to us. It produces bile essential for fat emulsification and digestion. So storage functions are vitamin and mineral storage. It does it. So it stores vitamins, all the vitamins and essential minerals. Glycogen storage is being done, shares glycogen storage as an energy source. If the patient is not consuming enough meals, then the liver may switch to glycogenolysis, wherein it converts the glycogen into the into the active form glucose. See, it also shows Kupffer cells activity in case of immunological perspective, which help in immune defense and pathogen clearance from the body. And at last, it also helps in hormone metabolism, that is modifies and deactivates hormones like insulin, estrogen, and corticosteroid. So these are the functions of the liver. Next slide, please. Yeah. So our importance. What causes liver damage? Okay, infections and inflammation. Firstly, so infection here can account to mainly hepatitis. We do know that there are five types of hepatitis viruses: hepatitis A, B, C, D, E. So these are one of the main reasons which can cause liver damage if they are in their active state. And inflammation can be a more precipitating factor due to infection. Next is bile flow obstruction. So bile flow obstruction might occur as a result of cholelithiasis, that is gallstone formation into the gallbladder. Steatosis is an effect wherein the liver gets covered with a fat layer. It can be a result of excessive alcohol consumption as well. I have separately listed alcohol as a factor because excessive alcohol consumption causes steatosis, and always liver failure can or cannot be attributed to alcohol consumption. So, and lastly, drugs are the of primary importance if the drug might hamper the the liver. And trauma, if there is any kind of trauma, any kind of damage, penetrating injury can be there to the liver. Just a second. Yeah. Hmm. Next slide, please. So what are the types of liver failure? Okay, acute liver failure is defined as severe acute liver injury for fewer than 26 weeks duration with encephalopathy and impaired synthetic function, that is INR, international normalized ratio of 1.5 or higher, in patients without cirrhosis or pre-existing liver disease. Okay, so acute liver failure is what there is an acute injury, acute insult of the liver, which can be characterized by encephalopathy, that is due to the toxins being released in the bloodstream. It may cause some brain damage as they accumulate inside the brain. INR can be on the higher side. Okay, and patient might or might not present with liver cirrhosis. Okay, so next is chronic liver disease is a progressive deterioration. It is a further step where the continuous process of inflammation, destruction, and regeneration of liver parenchyma leads to fibrosis and cirrhosis. This total destruction of the liver cells. So, cirrhosis is a final stage of chronic liver disease that results in disruption of liver architecture, the formation of widespread nodules, vascular reorganization, and neoangiogenesis, and deposition of an extracellular matrix. Okay, so nodules can be seen as the liver cells get damaged. They might form nodules which are encapsulated with inflammatory and all the debris, cellular debris is present inside it. Vascular reorganization, cells might divide. Liver cells might try to compensate for the loss of the cells. Neoangiogenesis and deposition of extracellular matrix. The waste or everything which needs to be evacuated from the body or thrown out is deposited in the liver itself. Next slide, please. So I will not elaborate much on this, as we do know that measurement of liver function is based on hepatic markers SGOT, SGPT. We do know that these levels are quadrupled in case of damage to the liver. Apart from that, we do use international normalized ratio, INR, and protein, along with bilirubin as well. So we do measure the bilirubin levels. This is the overall constitution of liver function test. Next slide, please. So what are the considerations? Impaired drug metabolism. So drug clearance is reduced, hence potentiality of buildup of higher concentration of drug in the body can be a possibility, as we know that the liver damage has set in. Liver is getting damaged. It can be result of anything: trauma, drugs, or alcohol. There is inflammation, infection is present inside the body. So all of these processes may contribute to the liver not functioning properly, and hence whenever we are treating the patient, there can be an impaired drug metabolism. So the drug might not get metabolized properly, it is not reduced to its form to be excreted out, hence it gets accumulated inside the body. Next is impaired elimination. As I said, if some drugs are explicitly excreted through bile, and hence as the bile production is impaired, accumulation can occur. Altered protein binding. As production of albumin might decrease, more of the unbound drug remains available in the bloodstream, potentiating adverse effects. As we did see in the kidney failure and liver failure as well, that proteins are primarily responsible for drug distribution inside the body. If proteins are present in less amount, as the production of albumin will decrease, the unbound drug remains freely available inside the body, which can cause hazardous adverse effects. Yeah, next slide, please. Yeah, so child per classification of severity of cirrhosis. Let me tell you that as we have seen for kidney function, we have the creatinine clearance, we have equations to calculate the clearance. In case of liver function, we use this child per classification to assess the severity of the cirrhosis. Okay, we do not directly measure, as we have seen the parameters on basis based on which we measure the liver function. We do not do this in case of liver failure. We do consider the parameters, but this is the scale which we follow. So what are the parameters? Ascites is whether ascites is present, absent, or is it in moderate levels. According to that, the points are being assigned to the patient. So next parameter is bilirubin, whether it is less than 2 mg per dl or more than that. In case of severe condition, severe cirrhosis, the bilirubin might get a twofold or threefold increase as well. So next is albumin. So albumin is the level of protein present in the blood. So it, as I said, that it affects drug binding. So this, it is also one of the parameters. Prothrombin time is one of the parameters. Prothrombin time or INR. We usually use INR in the, what we say, the calculator which we use. So INR is, if it is increased, it does indicate that the coagul coagulation of the blood, or the factors which are responsible for coagulation, are not being manufactured properly. So the blood is freely flowing. Next is encephalopathy, that is none, grade 1 or 2 or grade 3 to 4. Encephalopathy is the damage being done to the brain, okay, due to accumulation of toxins. So modified Child-Pugh classification of severity of liver disease according to degree of these all parameters is being measured. A total Child-Pugh score of 5 to 6 is considered Child-Pugh class A. Okay, so it is a well compensated disease. So we can attribute that patient is much healthier in this case, in case of Child-Pugh class A and class B, which does denote that significant functional compromise has occurred if the score is between 7 to 9. Okay, and lastly, if the score is too high, that is 10 or 15, class C decompensated disease. So it is permanent damage, and the patient might become a candidate for a liver transplant. It also, the Child-Pugh score does also give us the patient survival rate if the child weight between 100 to 85% for child class A, class B 80 to 60%, and class C 45 and 35%. If the patient progresses from class B to class C, as I previously said, he or she becomes a candidate for liver transplant. Next slide, please. So, which drugs are affected? So, opioids like morphine, tramadol, codeine, fentanyl, which are being given to patients, their excretion might get delayed. So, benzodiazepines are there, diazepam, clonazepam, antiepileptics. These drugs, especially these drugs, NSAIDs and antiepileptics, they do need dose reduction or switching the drugs, because these are primarily metabolized by the liver. So carbamazepine and sodium valproate, NSAIDs, all of them except acetaminophen. Yeah, acetaminophen, as we know, it is not an NSAID, so it remains first choice to manage pain in liver failure patients. We do say theoretically we have studied that paracetamol should be avoided in liver failure patients, but it is not the case. It remains one of the best choice for best choice for addressing pain. So antibiotics like macrolides, metronidazole, lincosamides, rifamycins, tetracyclines, to a smaller extent, are affected. Next slide, please. Yeah, so I have not deliberately included a case based on liver dose adjustment because, see, the classification is based on child bug score. Okay, so we do have specific recommendations available, but again, it depends on case to case scenario, and depends on the clinician's expertise as well, whether to reduce the dose or we can dose it in equal condition. Mostly, in case of liver failure patients, the drugs are best to be avoided, the drugs which I listed previously. Other than that, next options can be chosen, other options can be availed for. So these are some of the additional resources for reading. You can take a screenshot of it maybe and read when once you are done. Spend your Sunday happily reading this. Yeah. Next slide, please. These are my references. Next slide. Last slide, please. Yeah. So thank you so much. I am done from my side. Let's address some questions.
Thank you, sir, for enlightening our minds on the physiology of the kidney, the causes of its failure, its types, and why dose adjustments are important based on specific characters of the patient. We truly learned a lot when you highlighted the issues faced while drug dosing. The case presentations really helped us in solving our doubts, and we'll surely implement the given knowledge practically. Same goes with hepatic dose adjustments. So here are some few questions the audience would like to ask you, sir.
Yes, yes, please
What
go
are
ahead.
the major strategies what are the major strategies for renal dose adjustment?
Okay, so major strategies are for renal dose adjustment. As I previously mentioned, firstly, we have to look at the creatinine clearance. Okay, as we get the creatinine clearance from the Cockroach equation, which is the most widely used. Mind you that other two methods which I explained are also reliable, but I personally use, or I do not endorse it, but I use Cockroach equation for it. So once we get the creatinine clearance, we can do two things. Either we can prolong the interval, okay, the dosing interval, we can dose much more hours apart, or either we can reduce the dose. These are the main two strategies in case of normal, if the patient is not on any replacement therapy. In case of replacement therapy, again the scenario depends on basis of drugs. That's why I have provided the material. You can go there, read first. But let me summarize that when the patient is on CRRT or any kind of renal replacement therapy, there are specific recommendations available for some of the drugs that we can dose these drugs once the replacement therapy is done, because majorly what happens when we are treating the patient, the drugs usually get excreted out of the system, the body, through the fluid or through the mechanical machine which we have attached to the patient. So yeah, we might need redosing strategies as per the drug. Yeah, that's it.
The next question is only serum creatinine alone always a reliable indicator of renal function? Are there any other indicators?
Yeah, creatinine clearance, we do use it to assess the renal function. Apart from that, urine output is there. Symptomatic presentation, urine output is, I think, one of the major concern. In case of AKIs, especially if a patient is in AKI but his urine output is good, we might not even need, or no dose adjustment is mandated in such cases. If we, for example, let me just say that if we are putting 1 liter of fluid into the patient, okay, we are giving 1 liter of fluid. If the patient is giving an output of 1200, 1300, 1400 ml over the course of 24 hours, then it is a good output. Okay, So we might not necessarily mandate dose adjustment in such cases. So yeah, urine output is one indicator. Other than that, symptomatic presentation, as we initiate the therapy, we hydrate the patient. As the symptoms will improve, it is also an indicator for, yeah.
Moving on towards the next question. What are the clinical consequences of overdosing versus underdosing in renal impairment?
Sorry, can you repeat the question?
Yeah. What are the clinical consequences of underdosing versus overdosing in renal impairment?
So what are the consequences? Let me understand the question. What are the consequences of underdosing and overdosing? Okay, this is the question, right?
Yeah. Yes.
So logically speaking, if we underdose the patient, there we might see a delayed improvement. That is, the patient symptoms might not improve drastically or immediately. There is a slowed progression of the improved disease condition. If we overdose, the patient might suffer from adverse effect of the therapy itself. So patient might land into more renal failure, or what we can say. Just a minute. So where was I? The patient might land into much more severe condition if we overdose or we do not optimally dose the drugs. Again, why I am telling a generalized scenario, because all these parameters differ based on drugs. So to mentioning any specific drugs or might not be mandated to answer this question. But yeah, if we underdose, there might be delayed in recovery. If we overdose, there might be more harm to the patient. Just a basic idea that we need to optimize the drug dose according to all the parameters: patient symptoms, the biochemical parameters as well. Yeah.
The next question is, what are the challenges in dosing antibiotics in patients with renal failure?
Yeah, so dosing antibiotics, especially, I was expecting this question actually. Yeah, so antibiotics, which mainly get excreted through urine, most of them they are excreted through kidney. So challenges mainly faced is underdosing. In case of a normal function as well, there is sometimes it does happen that the physician might initiate or might start with a lower dose. So if the kidney function is appropriate, everything is fine with the patient, we can escalate the thing and can improvise the dose. Means we can achieve maximal concentrations by optimal dosing. In case of disease condition, yeah, we might need to adjust the dose. In case, as I previously said, there are two strategies: either reduce the dose, okay, keep the interval same, or prolong the interval and keep the dose same, or both can be done, or either of one can be done. So this is not a challenge, this is a strategy. So challenge is being that, again, patient might receive uh, less dose, which might affect the clearance of infection. Means the infection might land the patient into sepsis, or worst case scenario might happen. So what is to be done that, according to the patient condition being assessed, we might need to optimize the dose. It always depends on case to case basis. That's why I'm generally answering these questions.
Okay. How does hyperkalemia impact medication choices in CKD patients?
Hyperkalemia impact, sorry.
Medication choices in CKD patients.
Yeah, so hyperkalemia mainly, AC inhibitors do remain the choice of drug for them. Means they might precipitate hyperkalemia, but they do also remain choice of drugs to treat hypertension or other, means to treat CKD patients. Apart from that, choice of drugs, if you say, there are some marketed materials which do contain potassium salts, which are to be avoided. Sorry, I'm not able to recall exact at this time, but yeah, there are some materials or some drugs which contain potassium salt which are best to be avoided. in such patients. Yeah. Apart from that, we can always use potassium binding resins. And if the patient is on dialysis, yeah, we can if the patient is put on dialysis, we actually do have to supplement him or her with k bind sachet, or potassium supplements can be given.
How does aging affect renal drug clearance, and how should doses be adjusted in elderly patients?
How does, please repeat first question.
Aging, how does aging
Aging.
affect renal
Okay.
drug clearance?
Okay. How does aging affect? So, as I had mentioned, that creatinine is a byproduct of muscle metabolism. Okay. So, creatinine, as we know, it is a basic idea that in elderly patients, overall metabolic function and overall muscle mass gets decreased as the patient age or as the person ages. So, we might see decreased creatinine excretion in the patient, but this does not necessarily denote that patient might not be getting harmed. Okay, so we always need to assess all the patient specific parameters. So patient might get fluid overloaded, we might see edematous symptoms in the patient. Apart from that, the kidney function or the clearance might remain normal. Yeah, so it does depend on patient basis. And the second question was about the dose adjustment. Again, same case scenario. It depends on case to case scenario, which what are the drugs being dosed to the patient. But yeah, we do need to carefully assess. Means it is better to be staying on lower dose side in case of elderlies.
What are the most common drugs that require renal dose adjustment?
So, what are the most common drugs? Okay, so first is antimicrobials. All antifungals, antivirals, antiretrovirals are there. Apart from that, anti-diabetic medications that sulfonylureas might require, metformin as bigonide, which might require some of the statins. I think so. Yeah, they do require an adjustment. We can reduce their doses. Apart from that, not necessarily, not all the drugs do require. Yeah, these are the main ones which might necessitate dose adjustment.
What are the risks of NSAIDs in patients with liver failure?
Risk of NSAIDs. Okay. So NSAIDs are generally contraindicated because we do know that all the coagulable pathways are through run through the liver. Means all the factors which are responsible for coagulating the blood are manufactured inside inside the liver. So if we dose a patient with NSAID, if the patient has some previous history of blood loss or any kind of perforation or ulceration inside the body, so we do put the patient at risk of fatal bleeding, as there are no clotting factors available inside the patient's body to cope up with the blood loss. So yeah, NSAIDs are best to be avoided. Paracetamol is the best choice and the best option for NSAIDs.
Now the last question. In recent case, patient had right kidney nephrosis and urinary retention, and only during prescribed was tamsulosin hydrochloride. What will be the first choice of drug for such condition?
Oh, okay. Right kidney nephrosis was there, and what was there?
Urinary retention, and
Urinary
only drug
retention.
prescribed was tamsulosin hydrochloride.
Okay. So in such case, actually, we can switch the drug to more safer drug, silodosin, and to minimize the urinary retention, we can use dutasteride. Yeah.
Thank you, sir. Now I call upon our Honorable Secretary Anushka Taide to deliver the vote of thanks.
Good afternoon, everyone. So today, as we conclude our today's enlightening session on renal and hepatic dose adjustment, I, Anushka Taire, Secretary of ispor Student MCOP Chapter, I would like to extend our heartfelt gratitude to our esteemed speaker, Dr. Atharva Nanday, Your extensive insight into the complexities of renal and hepatic function and their implication on drug dosing were truly invaluable. You effectively highlighted the importance of personalized medicine, emphasizing how these adjustments can significantly enhance therapeutic outcomes and minimize the adverse effects. The case studies you shared not only illustrated the real world application of these principles, but also underscored the critical role healthcare professionals play in the patient safety. I would also like to appreciate our sport team for meticulously planning and execution that has made this event a resounding success. The seamless coordination and attention to the details truly reflects the commitment to advancing our knowledge in the pharmacotherapy. Lastly, I would like to thank your audience for patience and engagement throughout the session. A special thanks to Dr. Atharva Nanday sir for sharing such valuable insight and knowledge with us. We truly appreciate your time and expertise. Looking forward for such more sessions in the future as well. Thank you, everyone.
Yes, thank you so much. Thank you so much.
Thank you, sir.
Thank you, Sport Chapter.